Everyone. In this session, we are going to discuss a very important topic, that is ischemic heart disease, also known as coronary artery disease. So it's an ultra important topic from exam point of view. We will be discussing two important diseases here, that is angina pectoris and myocardial infarction. You are certainly going to get some questions from this topic in your exam, especially the long questions either on angina or on myocardial infarction, and there are many short questions also important from this topic. So let's start it. So here you can see we are starting the topic, that is ischemic heart disease, also known as coronary artery disease. IHD, ischemic heart disease, also known as coronary artery disease, that is CAD. So I will be discussing the topic under following headings. First of all, I will let you know what is ischemic heart disease or what is coronary artery disease. What do you mean by that? Then to understand the topic, first you have to understand the coronary artery blood distribution in the heart. Then I will tell you the effects of various types of ischemic heart disease. Among them, we will be discussing two in detail. Which two we will discuss in detail? We will discuss angina pectoris and myocardial infarction. In angina, I will be telling you the definition of angina and the three types of angina, the pathogenesis, clinical features of each of them, the stable angina, unstable angina, and Prinzmetal angina. In MI, you frequently get long questions, so we will be discussing that MI, that is myocardial infarction, in detail. I will let you know definition, etiopathogenesis, type of infarct, location of infarct, gross, microscopy, clinical features, diagnosis, and complications of MI. So if you are getting a long question, you have to write your answer under following headings in case of long question, or else you will be getting short question on each of them, on either of them. So you have to write that portion only. So let's start it. First, let me tell you what is ischemic heart disease or coronary artery disease. So ischemic heart disease or coronary artery disease arises from imbalance. Imbalance between what? Imbalance between two things, the myocardial supply and demand for oxygenated blood. So it's very important to understand what is demand and supply. If there is an imbalance in demand and supply, it will lead to ischemic heart disease or coronary artery disease. But what is demand and what is supply? The myocardial oxygen demand and myocardial oxygen supply. You have to understand it clearly. Now here you can see a diagram. In this diagram, I am going to tell you the demand and supply of myocardium, oxygen demand of myocardium, the demand and supply. So in this diagram, you can see the heart. You can see the four chambers of the heart. Now, can you see the left ventricle here? Let me highlight left ventricle. I am interested in left ventricle. Now, when we all know, when the left ventricle contract, what happens? The blood is pumped in the aorta. The blood is pumped, it is ejected in the aorta. Via aorta, this blood is pure oxygenated blood. On the left side of the heart, we are having oxygenated blood. So this pure oxygenated blood is pumped in the aorta, and via aorta, it is going in all organs and it is distributed in all organs. So basically, all the organs from head to toe, all the organs of the body receive oxygenated blood from the heart via aorta, from the left side of the heart, from the left ventricle. Yes or no? Of course. Okay. But who gives blood to the heart? Have you ever thought? All the organs receive blood now. Heart is also an organ. So heart also require blood. Who is giving blood to the heart? Heart is giving blood to all the organs. Who is giving blood to the heart? So you can see from the aorta, an artery is arising. Can you see this artery? Let me show you. So I'm talking about this artery, the coronary artery. From the aorta, you can see this is coronary artery. I have marked with purple color. So this coronary artery is arising from the aorta and it is giving blood to the left ventricle, the wall of the left ventricle. To entire heart, it gives the blood. So this is the coronary artery. So I guess everyone knows this. Okay, now the question arises, how does left ventricle contract? Do you know how does left ventricle contract? So when the left ventricle is contracting, then only blood is ejected in aorta. But how does left ventricle contract? So see the wall of the left ventricle. Can you see left ventricle? Don't see the lumen. See the wall. Can you see the wall? In the wall of the left ventricle, there are cells. These are known as cardiomyocytes. These are the myocardial cells. You can see these are the myocardial cells. When they contract, systole occurs, and when they relax, the diastole occurs. So when these cells are contracting, the left ventricle is contracting, and when these muscles are relaxing, the left ventricle is relaxing. That is diastole occur. Okay, so how does these cell contract? So basically, we want the contraction of these cells. So to contract, These cells require ATP. Of course, all cells require ATP to contract. So these are also cells, the myocardial cells, they require ATP to contract. So to synthesize the ATP inside them, they require oxygen. And oxygen, from where they receive the oxygen? To receive the oxygen, they require oxygenated blood. They require pure blood, oxygenated blood. And this pure or oxygenated blood is given by the coronary artery. So basically the coronary artery supplies oxygenated blood. Okay, from the oxygenated blood, the oxygen is taken. The oxygen is utilized in the synthesis of the ATP, and that ATP is required for contraction of these cells. And when these cells contract, the left ventricle contract. When the left ventricle contract, the blood is ejected in the aorta. It is pumped in the aorta, and via aorta it is distributed in all organs. So this coronary artery blood is very important, and this is known as demand of the heart, demand of the myocardium, oxygen demand of the myocardium to contract. So this much. So basically what we understood, demand depends on the organ activity of the organ. If there is more activity in the organ, more demand is there. If there is less activity, less demand is there. I will explain. Okay, so this is known as demand. The blood in the coronary, the heart is demanding that much amount of blood via coronary, the pure blood, the oxygenated blood, so that the left ventricle can contract, the myocardial cells can contract, and left ventricle can contract, and heart can fulfill the requirement of the organs, the activity of the organs. So this is known as demand. And how much actually we are supplying via coronary, this is known as supply. So there is demand and there is supply. What is supply? Supply means how much coronary is actually supplying the heart. So this should match. The demand and supply should match. Supply directly depends on the lumen of the coronary artery. So if the coronary artery is dilated, more blood is given, more supply is there. If the coronary artery is constricted, it is constricted, vasoconstriction is there, less blood is given to the heart, so less supply. So supply directly depends on the lumen of the coronary artery. It's common sense. So basically coronary artery is the artery which is supplying blood to the left ventricular wall. We are interested in left ventricle. So coronary artery is the artery which is supplying blood to the left ventricular wall. So lumen of coronary artery is very important. If the lumen is broad, it is vasodilated, more blood will be supplied. If the lumen is contracted, less blood will be supplied. So basically the supply depends on the lumen of the coronary artery, and how much the heart require, the left ventricle is requiring, that is demand. The demand is depending on the activity. Now please understand, suppose we will take two conditions, more activity, less activity. So let's start with less activity. All the organs are at rest. The body is at rest. Suppose the body is at rest. Okay, what will happen when my body is resting? I'm not doing any particular activity. So I just require blood to maintain the basal metabolism. So basically my organs are requiring less blood at that time. Yes or no? So during rest, my body require less blood. Okay, so we will demand less blood. We want aorta to give less blood only. So we want the left ventricle to contract less only, so that less blood will come in the aorta. So we want the myocardial cells to contract less only, then only left ventricle contractility will be less. So we want coronary artery should have less blood will suffice. Okay, so I mean the demand is less. In this case, the demand is less. Okay, demand is less. And even if the normal lumen is there, the coronary artery have normal lumen, it's not very dilated, normal lumen is there, so supply, there will be less supply. So less demand, to fulfill the less demand, we need less supply, which is fulfilled by normal lumen of the coronary artery. We don't have to dilate it. So this is a scenario. The first scenario, you can see what I said, if the body is at rest, there is less activity, the body require less blood, all the organs require less blood. So we want aorta to give less blood. Okay, so we want left ventricle to contract less only. Okay, so we want the myocardiocytes to contract less only. So we want the coronary should have less blood, so demand is less. So supply should also be less, and that is fulfilled by normal lumen only. So this is the first scenario. Now let's take the second scenario. Suppose the body, we are doing some exercise. I'm doing some exercise, running, jogging, anything. At that time, my activity is more. So my all organs, especially the skeletal muscle or other organs, they are requiring more blood. Okay, they require more blood at that time. So we want the aorta to give more blood. So we want the left ventricle to contract more so that aorta can receive more blood. So we want the left ventricular cells, myocardial cells to contract more. So we want the coronary to have more blood. So here the demand is more. The demand is more. So to fulfill more demand, we should have more supply. We should have more supply. How more supply will be given? By dilating the coronary artery. So during exercise, the coronary artery get dilated. Coronary artery get dilated to fulfill more demand, to give more supply. If there is more demand, there should be more supply. To fulfill that, the coronary artery get dilated. So whenever my body is at rest, my coronary have normal lumen. It is supplying normal blood or less blood to the left ventricle. So my left ventricle is contracting less blood is given to the aorta and less blood given to all organs, and that is suffice during rest. But during activity, during exercise, during running, during jogging, what happens? My organs require more blood. Okay, so at that time my coronary get dilated. My coronary give more blood to left ventricle will contract more blood to aorta, more blood to organ. So my body is doing the balance between demand and supply. Whenever the demand is less during rest, the demand is less, the supply is also less. The supply is also less via normal lumen of the coronary. But whenever the demand is more during activity, running, jogging, the demand is more, we have to increase the supply of the coronary by dilating the coronary. So whenever there is a balance between demand and supply, there is no problem. My body require less blood, heart contract less, and less blood will be given to heart. But whenever my body require more blood during activity, heart contract more and more blood will be given to heart via coronary, via dilating coronary. This is known as balance. Balance between what? The demand and supply. The demand and supply. Till now balance is there. But now please understand the imbalance. What happens if imbalance occur? It will lead to the disease we are studying right now, the coronary artery disease or ischemic heart disease. How does the imbalance occur? Now imagine a situation. Imagine if there is obstruction in the coronary. Imagine the coronary got obstructed. What will happen? If the coronary got obstructed, what will happen? You tell me what will happen. So less blood will go to the coronary and less blood will be supplied to left ventricle, to the left ventricular cells. Less blood will be given. So left ventricular cells will contract less. So left ventricle will contract less. So less blood will be given to aorta and all the organs will receive less blood or no blood. Sometime if the coronary is completely obstructed, no blood will be given. No blood will be given to the left ventricle. So basically that portion of the left ventricle, the cells in the left ventricle, they will undergo ischemia. You know, if any organ in human body, any cell in human body do not receive blood, the cells of that organ undergo ischemia. Ischemia will happen in those cells or in that organ. So if the coronary got obstructed, partial or complete, if there is obstruction in the coronary, a portion of the left ventricular cells is not getting blood. That portion of the left ventricle, the cells of that portion undergo ischemia followed by infarction. So that portion will not participate in the contractility. So when the left ventricle is contracting, we need all the cells present in the left ventricle should contract so that contractility will be very efficacious. But here a portion of the left ventricular cells are not participating in the contractility because they are infarcted. They are dead. So the remaining cells are undergoing the contraction. So the contraction will be less. It will be less intensity. So less blood will go in aorta and all the organs will receive less blood or no blood, and that is known as coronary artery disease. Why it is known as coronary artery disease? Very simple, because it occurs because of obstruction of coronary. That is coronary artery disease. It is also known as ischemic heart disease. Why it is known as ischemic heart disease? One and the same thing. If the coronary got obstructed, what is happening? There is ischemia in the wall of the left ventricle. So one and the same thing. Either you say obstruction in the coronary or you say ischemia in the wall of the left ventricle, because obstruction in the coronary is leading to ischemia in the wall of the left ventricle. So coronary artery disease, also known as ischemic heart disease. So this is the basics you must understand. And why does it is happening? Because of imbalance between demand and supply. So demand is more, but supply is less. Now imagine I am doing exercise. Imagine a human being is there, a person is there whose coronary is obstructed. Imagine, and that person is doing exercise, running, jogging. Okay, so at that time the activity is more. The activity is more. The organ require more blood. So we want aorta to give more blood. So we want left ventricle to contract more. Okay, so we want the coronary to dilate, but the coronary is obstructed, unfortunately, in this case. So coronary cannot dilate, coronary is not giving enough blood. Okay, and a portion of the left ventricle is not participating in the contracting. So demand is more, but supply is less. Demand is more, but supply is less. So it is giving imbalance, and that is known as ischemic heart disease or coronary artery disease. I hope you got the concept well. So this is the definition. Definition is very simple to learn, but it is difficult to understand, but I tried my best to help you in understanding. So what is the definition? The definition is imbalance. Imbalance between what and what? Between the demand and supply of the myocardium. Whenever there is an imbalance between demand and supply, it will lead to ischemic heart disease or coronary artery disease. So after the definition, okay, have a look on this diagram on this video. See, this is coronary artery. See the lumen of the coronary artery. So first the lumen is complete. See, the lumen is complete. So heart is contracting more. You can see the left ventricle. This is the wall of the left ventricle. It is contracting sufficiently because it is getting enough blood. But whenever there is atherosclerosis in the lumen of the coronary, the lumen is obstructed. So you can see the less blood is coming. So when less blood is coming, so contraction will be less. So when normal blood is coming, contraction is more. When less blood is coming, contraction is less. So contraction of the left ventricle directly depends on the blood supply of the coronary. If the blood supply of the coronary is more, left ventricle contract judiciously. If the blood supply in the coronary is less due to any reason, maybe atherosclerosis, maybe thrombosis, maybe vasospasm, due to any reason, if the blood supply is less, left ventricle will not contract very efficaciously. So this is the thing you have to understand. Now, after getting the definition of coronary artery disease, you must understand the coronary artery distribution. So there are two types of coronary arteries, left coronary artery and right coronary artery. Left coronary artery and right coronary artery. Right coronary artery don't have any branches. It is only RCA. It don't have any branches. But left coronary artery is divided into two branches. That is left anterior descending and left circumflex. Left anterior descending, LAD. Left anterior descending and left circumflex, LCX. LCX is left circumflex, you can see. So total 3 coronaries are there. How many coronaries we are having? We are having 3 coronaries. Left anterior descending, left circumflex and right coronary artery. So these 3 coronaries are there. Now you have to see which coronary is supplying which portion of the heart. So you can see this is the heart. If we cut the heart from here, if I'm cutting the heart from here and looking from above, you can see this is the heart. These are the 4 chambers in the heart. This is the right side. This is the left side. And I am cutting the heart from here and looking from above. Okay. So I can see the 2 lumen, 1 lumen of right ventricular cavity and 1 lumen of left ventricular cavity. So same slice is shown to you. You can see this is right ventricular lumen and this is left ventricular lumen. I have cut the heart from here and looking from above. I hope you got this. So I'm cutting the heart from here and looking from above. You can see this is right ventricular. This is left ventricular lumen. Now I am interested in left ventricular wall. So left ventricular wall is divided in 4 portions. This is anterior. This is posterior. This is medial and this is lateral. You can see. So which coronary? We are having 3 coronary and we are having 4 portions in the wall. Anterior portion of the wall, posterior portion of the wall, medial portion and lateral portion. So which coronary is supplying which portion of the heart? Okay. So we can see the anterior portion of the heart is supplied by left anterior descending. Can you see this red color? The anterior portion of the left ventricular wall is supplied by LAD, left anterior descending. Okay, the lateral portion, you can see this lateral portion, it is supplied by left circumflex and the posterior portion is supplied by RCA. It is supplied by RCA. What about the medial portion? So anterior wall is done, posterior is done, lateral is done. What about the medial portion? So medial portion, the anterior 2/3 of the medial portion is supplied by, it is supplied by LAD only and the posterior 1/3 of the medial wall, it is supplied by RCA. I hope you got it. I will draw it again to explain you. So let's revise it. You can see this is heart. You can see the 4 chambers of the heart. You can see right, left. This is right ventricle and left ventricle. Okay. So let's cut the heart from here and look from above. So I can see like this. These are the 2 lumen. This is right ventricular lumen. This is left ventricular lumen. Now I am interested in the walls of the left ventricle. So this is anterior portion of the wall. This is posterior portion of the wall. This is lateral portion of the wall. And this is medial portion of the wall. Look at only left ventricle. I'm not interested in right ventricle. Look at the left ventricle because maximum infarcts occurs in the left ventricle. So we can see the wall of the left ventricle. Can you see the wall of the left ventricle? I'm talking about this. So this is the wall of the left ventricle. See the lumen of the left ventricle and see the wall of the left ventricle. So we divide the wall of the left ventricle into anterior, posterior, medial and lateral. Now which portion is supplied by which coronary? We are having 3 coronaries. So the anterior portion is supplied by LCA. The lateral portion is supplied by LCX. Okay, this is left anterior descending, LAD. LAD, left anterior descending, the anterior portion. The lateral portion is LCX, left circumflex. The posterior portion of the wall is supplied by RCA. What about the medial portion? We are having only 3 coronaries, but we are having 4 portions in the wall. What about the medial portion? The anterior 2/3 is supplied by continuation of LAD and the posterior 1/3 is supplied by continuation of RCA. So this is how blood supply takes place. Now you can imagine any of the 3 coronary can get obstructed. Depending, that portion of the wall will undergo infarction. Now imagine if LAD got obstructed, there will be an infarct in the anterior wall. If LCX got obstructed, there will be an infarct in the lateral wall. And if RCA got obstructed, there will be an infarct in the posterior wall. So depending, medial wall infarct is very rare or it don't exist or it's very rare. So you can see depending on the coronary, which branch of coronary get obstructed, the location of the infarct is there. So infarct is in anterior wall, posterior wall or lateral wall. It depends on which coronary is obstructed. So most commonly LAD get obstructed. Most common. So most common infarct you get in anterior wall. Second most common is RCA. Second most common. So second most common infarct are in posterior wall and rarely you get the obstruction of LCX. Very rarely. So lateral wall infarcts are very rare. Okay, and medial wall infarct don't exist. Actually, in the medium, it is interventricular septum. It's not a wall. It's the interventricular septum in the medial wall. So there is no infarct of that. So you can understand the location of the infarct depending on the branches of the coronary. Now let's start our disease. That is ischemic heart disease. You got the orientation. Now let me tell you what happens if ischemic heart disease occurs to any person. What is ischemic heart disease? Imbalance. Imbalance between demand and supply of the myocardium. Myocardial oxygen demand and supply, if there is an imbalance. So 4 things can happen. If the coronary get obstructed, either the patient may be asymptomatic, but if the patient is symptomatic, 4 conditions can be there. The person can have angina, the person can have MI. MI is myocardial infarction, or the person can have chronic ischemic heart disease, or it can be sudden cardiac death. So out of these 4 consequences of ischemic heart disease, I will be explaining you these 2. Basically, ischemic heart disease or coronary artery disease is the umbrella term. It can lead to any of the 4. So depending from patient to patient, it can be any of the 4. In some patient, it can lead to angina. In some, it is infarction. In some, it is chronic ischemic heart disease. And if the person is very unfortunate, it can be sudden cardiac death also. So depending on person to person, there are various factors which disease will occur, which symptom will occur in ischemic heart disease. So we'll see the detail of angina and MI. So let's start with angina. First, I will be telling you angina and then we will come on MI. So angina pectoris. Let's start angina pectoris. What is angina? Can you define angina? In simple words, angina is simply chest pain. It is chest discomfort. Rather than saying chest pain, say the word discomfort. It is chest discomfort. Which portion of the chest? Which portion of the chest? It is just substernal, below the sternum, or precordial. Substernal or precordial chest discomfort. And it comes in attacks. It is not continuous. Some diseases are there in which the symptoms are continuous. The symptoms are continuous like this. Some diseases are there in which symptom come, symptom go away. And the person is absolutely normal between 2 episodes. So this is known as the disease come in attacks, like asthma. Have you heard about asthma? So you know what is asthma. In asthma, when the asthma attack is coming, at that time the person is having symptoms. Otherwise, between 2 attacks, the person is absolutely normal. So angina is just like asthma. I mean, it comes in attacks, and attacks is known as paroxysmal. The disease is paroxysmal in origin. It is paroxysmal. It is sudden, paroxysmal, and repeated attacks come. Recurrent attacks come. So it is paroxysmal. It is recurrent attacks of chest pain. It is transient in nature. Of course, it's transient. So between two attacks, person is normal. So transiently attack come, it goes away. Again, the person is normal. Again, the attack come. So it is transient. And why does it happen? Now imagine, you can see the coronary. Imagine the coronary got obstructed. What are the reasons of obstruction of coronary? I will tell you later on. So depending on the what is the reason for obstruction of coronary, there are three types of angina. We will discuss. So there are three types of angina. So whenever there is an obstruction in the coronary, maybe due to atherosclerosis, maybe due to thrombosis, maybe due to vasospasm, due to any reason. So what will happen? So a portion of the left ventricular wall, a portion of the cells of left ventricular wall is not receiving enough blood. It is receiving less blood. There is partial obstruction. So they are receiving less blood. So they undergo ischemia. They do not undergo infarction. Mind my words. I'm saying they undergo ischemia. They do not undergo infarction. So there is ischemia. There is transient ischemia. And once the blood supply is restored, the ischemia goes away. That's why it comes in attack. I will explain how does the ischemia go away. So it is transient ischemia. So you have to highlight the word. There is transient ischemia. It is not persistent. It is not permanent. And there is no infarction. If infarction occurs, infarction means cell death, it's necrosis. If infarction occurs, it's MI, my next disease. After angina, I'm going to teach you MI. So in MI also the same thing will happen. In angina as well as in MI, one thing is common, the coronary is obstructed. So if the coronary is obstructed, two things can happen. Coronary is temporarily obstructed or permanently obstructed. If it is obstructed, it is not giving supply to a portion of the cells in the myocardium. A portion of the cell in the myocardium is not getting the blood. But is it temporary or permanent? If it is transient, if it is temporary, with few minutes, few seconds, it goes away. So it is only ischemia. But if it is permanently obstructed, after ischemia, it will lead to infarction. I mean cell death. Once the cell death, it cannot be recovered. So ischemia is recovered, but infarction is not recovered. Okay. So angina, it comes in attack. Pain, chest discomfort occur, but it is an attack. Between two attacks, the person is absolutely normal. But in MI, the chest pain is persistent and it's more dangerous. Okay. So first, let's concentrate on angina. What is the definition of angina? Angina pectoris. It's a type of ischemic heart disease. So of course, all ischemic heart disease have imbalance. All the ischemic heart disease have imbalance between demand and supply of the myocardium. Myocardial oxygen demand and supply, there is an imbalance. So that is applicable for angina also. Here the patient present with chest discomfort. Don't say the word pain, say the word discomfort. Highlight the word discomfort. So because the patient don't have pain, patient have heaviness in the chest, a squeezing feeling in the chest. So we would say the word discomfort more correctly here. Patient is having chest discomfort and the disease is paroxysmal. Paroxysmal means it comes in attacks. It is not continuous and it is having recurrent episodes. So main thing, because of imbalance here, because of imbalance between demand and supply, the main thing which is happening here is ischemia. Ischemia in the left ventricle. Left ventricular cells. In the wall of the left ventricle, there is ischemia and that is transient in nature. It goes away after few minutes. It is not persistent. It is not infarction. So it is not persistent. It is not infarction. It's transient ischemia in the left ventricle due to this imbalance. That leads to chest discomfort. That is paroxysmal and recurrent. So this is the definition of angina pectoris that you have to reproduce in your own words. Don't mug it up. Please understand it and reproduce in your own words. So this is angina pectoris. Here the cardiac markers are normal. Because here infarction is not taking place, the cell rupture is not taking place, cell death is not taking place. The cells are transiently going in ischemia. That's why the cardiac markers are normal. And this is how we differentiate between angina and MI. Suppose a patient is coming to me with chest discomfort or chest pain. So I'm confused, is it angina or is it MI? So we can check for the cardiac markers. If they are normal, it's angina. If it is raised, it's MI. Okay, now coming on the types of angina. There are three types of angina. What are the three types of angina? Stable angina, unstable angina, Prinzmetal angina. Learn their other names also. Stable angina, also known as classical angina. Most common angina among the three is this one only. Unstable angina, also known as crescendo angina. And Prinzmetal angina, also known as variant angina. So first learn their two names. Now, on what basis this classification is there? Why anginas of three types? What is the basis of this classification? So in all angina, I told you one thing is common, the coronary artery obstruction. Now you must be thinking, ma'am, what is obstructing the coronary? So there is obstruction in the coronary. We got that. There is obstruction in the coronary. But what is obstructing the coronary? Is it a atherosclerosis which is causing the obstruction? Is it a thrombus which is causing the obstruction? Or is it simply vasospasm of the coronary which is causing the obstruction? That is deciding the type of angina. So in stable angina, there is atherosclerosis in the coronary. You can see, first see normal coronary. The lumen is patent. There is nothing in the lumen. This is normal coronary. Now have a look on the stable angina. In stable angina, you can see the atherosclerotic plaque in the coronary, which is causing the obstruction in the flow of the coronary. In unstable angina, there is a thrombus, superadded changes in the atherosclerosis. Here simply atherosclerotic plaque is there, no superadded changes. Here superadded changes like thrombus is also there along with atherosclerosis, which is causing obstruction in the coronary. So that is unstable angina. And in Prinzmetal angina, it is vasospasm of the coronary. Can you see there is vasospasm of the coronary, which is causing the obstruction in the flow of the coronary. So coronary got obstructed in all three. That's how it is angina. So, of course, in angina, the coronary got obstructed. But what is the cause of the coronary obstruction? Is it atherosclerosis? If it is atherosclerosis, it's stable angina. Is it thrombosis? If it is thrombosis, it is unstable angina. Is it vasospasm? If it is vasospasm, it's Prinzmetal angina. So these are the three types of angina. One by one, we will see the details. So first angina is classical angina, also known as stable angina. Among the three types of angina, it is the most common one. It is the most common one, as I told you. Here, the main cause is atherosclerosis in the coronary. Can you see the coronary? Can you see this coronary? Can you see the obstruction in the coronary is caused by atherosclerotic plaque? Here, the most important thing you have to understand, here patient have chest discomfort only on exertion, not on rest. Patient have chest discomfort only on exertion, not on rest. Why it is like that? You have to understand. Please see. So when the coronary is having atherosclerosis in the lumen, it's partial obstruction. So here blood flow in the coronary is not zero, it's less. I'm saying partial obstruction. Due to atherosclerosis, there is partial obstruction in the lumen of the coronary. Can you see the lumen of the coronary? Please see the coronary. Can you see the lumen? Can you see it's partially obstructed? So I will not say no blood is passing through the coronary. Partially it is passing. So blood in the coronary is less. So less blood in the coronary is there. So coronary is giving less blood to the left ventricle. Left ventricle will contract less because it is receiving less blood. Less blood, less oxygen. Less oxygen, less ATP. Less ATP, less contraction. Okay. So coronary is giving less blood to the left ventricle. Left ventricle is contracting less, not very much. It is contracting less. So less blood will go in the aorta. Less blood will be received by all organs, but that less blood is sufficient for rest. When my body is at rest, suppose I'm having this angina, classical angina. So when I'm resting, I'm not doing any activity, I'm resting, I'm having classical angina, suppose, and I'm resting, so my body requires less blood. Okay, and my coronary is obstructed with atherosclerosis. Okay, the patient's coronary is obstructed with atherosclerosis. So coronary is giving less blood to the left ventricle is contracting less, aorta is receiving less blood, all the organs are receiving less blood. But that much is sufficient for rest. So during rest, I don't have any symptom. The patient don't have any symptom. But suppose the patient is running, jogging, doing some exercise, doing any activity. At that time, the organs require more blood. At that time, organs require more blood because my skeletal muscles are contracting. I'm doing exercise. So I want the aorta to give more blood to me. So aorta will ask the left ventricle to contract more. But for contracting more, the left ventricle require more blood. So it will ask the coronary to dilate and give more blood. But normal, if it was a normal person, the coronary will dilate and give more blood and fulfill the demand by giving more supply. But here coronary cannot dilate. In this case, coronary cannot dilate. Coronary artery cannot dilate because there is a atherosclerotic plaque in the coronary. So it's a fixed lumen. It's a fixed lumen. You can see here. This is the coronary artery. You can see in the video. So coronary artery cannot dilate because it is having atherosclerotic plaque in the lumen. It is having a fixed lumen. Even at the time of exercise, normal coronaries get dilate, but here the coronaries will not dilate. So when the coronaries will not dilate, it still keep on giving less blood to the heart. So left ventricle will contract less only. It will give less blood to the aorta. Organs will receive less blood. Organ require more blood during activity, but they are not getting more blood during activity. They are having less blood only. Okay. So here transiently, because of the imbalance between demand and supply. So demand is more, but supply is less. So transiently, because the of imbalance between demand and supply, ischemia occurs in the wall of the left ventricle. In the cells of the walls of the left ventricle, transient ischemia occur. So patient have chest discomfort. So patient have heaviness in the chest. When I'm doing the jogging, running, I'm having heaviness in the chest. I'm having a squeezing feeling, something in the chest. So I will stop and I will do some rest. Whenever I'm doing some rest, the pain disappears, the discomfort disappears, because again at rest, that much less blood is sufficient for everything, and transient ischemia in the left ventricular heart wall, it goes away. So it's transient in nature. During rest, there is nothing, no symptom, but during exertion, chest discomfort occur. So this is the reason. I hope you got it. Most important finding in classical angina: chest discomfort occur at exertion, not at rest. It is relieved at rest. This is a classical finding, classical symptom in classical angina, the stable angina. And the reason you got it, it is due to coronary atherosclerosis. The coronary cannot dilate. It is having a fixed lumen. So I insist on the word discomfort. It is not pain. It is discomfort. Discomfort means it is heaviness, pressure, squeezing feeling, choking feeling, smoothing. It is not a frank pain. So use the word discomfort in your exam. If you ask the patient, can you describe the pain in your words? How does the discomfort occurs? How does the pain occurs? So patient will put the hand on the left side of the chest like this, and patient will say to you, doctor, I'm having some this kind of feeling. Patient will make a fist, and patient will say, doctor, I'm having this kind of feeling in my chest. It's not pain. It's something like this. This is known as Levine sign. So patient, he or she will typically place their hand over the sternum, and they will have a clenched fist. It's like a squeezing feeling. Someone is squeezing my heart. It's like that. That feeling the patient is having, and it is known as Levine sign. It typically exists for 2 to 5 minutes. After 2 to 5 minutes of rest, it disappears. It's transient in nature. So you have to learn. And it is crescendo and descendo in nature. So first pain increase in intensity, then decrease, and then disappear. It typically lasts for 2 to 5 minutes. So please learn the features. So what we have learned for classical angina, what we have learned for classical angina, what is the cause here? The cause here is atherosclerosis in the coronary artery. Here the pain occur only at exertion. At exertion, the pain occur, but at rest, the pain disappear. I mean, the chest discomfort disappear. The discomfort occur only for 2 to 5 minutes, not more than that, and it is crescendo descendo in nature. These are the features of classical angina. Coming on the second type of angina, that is unstable angina. What is unstable angina? What is the cause here? Here the cause is thrombus. You can see the coronary artery is again obstructed, but this time the cause of obstruction is not atherosclerosis. The cause of obstruction is thrombosis. So there are superadded changes in the atherosclerotic plaque along with thrombus. Here also the patient have chest discomfort, but see the three features. The patient have chest discomfort even at rest. In contrast to classical angina, patient was having chest discomfort only at exertion, not at rest. Here it occurs at rest also. The second finding, in classical angina, it lasts for 2 to 5 minutes. Here it lasts for more than 10 minutes. Here it lasts for more than 10 minutes. Here it is severe and new onset, and it is only crescendo in nature. It is not crescendo descendo, in contrast to classical angina. In classical angina, the pain was crescendo and descendo in nature. Here pain is only crescendo in nature. It's of new onset. It occurs even at rest, and it is more than 10 minutes. So if any one of the finding it is fulfilling, it will fit the criteria of unstable angina. So this is unstable angina. Can you see the diagram? See the lumen of the coronary. Here we have atherosclerotic plaque with superadded thrombosis. Okay, so you got the features. Now the third and the last type of angina is Prinzmetal angina, also known as variant angina. Here what is happening? Here vasospasm occurs in the lumen of the coronary. You can see vasospasm. Vasospasm occurs in the lumen of the coronary. There is focal vasospasm. So there is no atherosclerosis, there is no thrombosis. There is focal vasospasm in a portion. It is not complete. It is not diffuse vasospasm. It's focal. A portion of the coronary undergo vasospasm, and after some time, few seconds, it will automatically again dilate it. So this is vasospasm. So this pain occurs at rest. Here the treatment of choice will be vasodilator. So in case of Prinzmetal angina, it will be vasodilator. So treatment of the three angina will differ depending on their cause. So what we have learned angina. So we have started ischemic heart disease. We have seen what is ischemic heart disease, what are the effects of ischemic heart disease, and we have completed one portion of the ischemic heart disease, that is angina. So in angina, we see the definition and the three types of angina. What is the definition of angina? Let's revise angina and move on MI. So we have completed angina. Angina pectoris. What is angina pectoris? What is the definition? It's chest discomfort. Chest discomfort which is transient, which is due to transient ischemia. It is paroxysmal. It comes in attacks. It is not continuous. It is paroxysmal in origin, and it is recurrent in nature. So that, and this occurs, of course, due to imbalance between demand and supply. So this is the definition of angina. Now there are three types of angina we have seen. What are the three types of angina we have seen? Classical angina, also known as stable angina, unstable angina, and third one is Prinzmetal angina, also known as variant angina. So what is the cause of obstruction? Here the cause of obstruction is atherosclerosis. Here the cause of obstruction is thrombosis. And here the cause of the obstruction is vasospasm in the coronary artery. All three things in the coronary artery. Now what are the features? Important features here: chest discomfort occurs at exertion, but not at rest. Not at rest. At rest, it relieves. And in both of them, the chest discomfort occurs even at rest also. It is not related only to exertion, even at rest also it occurs. Here it lasts for 2 to 5 minutes. Here it lasts for more than 10 minutes. Here no duration, no particular duration is defined. Here pain is crescendo and descendo in nature. Here pain is only crescendo in nature, and here nothing is defined like that. So this is all about angina we have summarized. Now let's start myocardial infarction. So let's start myocardial infarction, MI. Okay, I will be discussing myocardial infarction under following headings. First, I will let you know the definition, then etiopathogenesis, then types of infarct, location of infarct, gross, microscopy, clinical features, diagnosis, and finally the complications. So let's start MI. What is MI? So let me tell you the definition of MI. Its definition is same. Again, there is an imbalance between demand and supply, because angina as well as MI both are coming under ischemic heart disease. So the origin of both of them is same. It is imbalance between demand and supply of myocardial oxygen thing. So here also there is a obstruction in the coronary. Let's do obstruction in the coronary. Again, same three reason. It can be atherosclerosis, it can be thrombosis, it can be vasospasm. But here obstruction is permanent. The obstruction is permanent, and because of the permanent obstruction, the left ventricular wall undergo infarction. It is not ischemia. You have to highlight the word here, infarction. Infarction means necrosis. It is ischemic necrosis. The cell got ruptured. It is death of the cell of the left ventricle. So in the left ventricle, the cells undergo death. It cannot be retrieved again. The cells are dead. It is infarction of the myocardium. So that is the definition. So you can see when the coronary got obstructed due to any reason. If the coronary got obstructed, maybe atherosclerosis, maybe thrombosis, maybe vasospasm. So a portion of the heart, the left ventricle of the heart will not receive blood, and cells of that portion undergo death. Cells of that portion undergo death, and that is known as myocardial infarction. A portion of the left ventricle, cells of left ventricle undergo death, that will not participate in contractility now. So this is known as myocardial infarction. You can see it here. You can see the myocardium is contracting very subtle. It is not having a very intense contraction because a portion of the left ventricle is dead, because it is not receiving enough blood. The coronary is obstructed. Since the coronary artery is obstructed, a portion of heart is not receiving enough blood, the left ventricle especially, and that portion undergo death, and the complete myocardium is not participating in contraction. So that is myocardial infarction. The etiopathogenesis is same like that of the three type of angina. What is the cause of obstruction? If the coronary got obstructed, what can be the reason? There can be three reasons. Again, same three reasons. The cause of obstruction can be atherosclerosis in the lumen of the coronary. The cause of obstruction can be thrombosis in the coronary. And the cause of obstruction can be vasospasm in the coronary. So any of the three reasons can occur. The reasons are same. Now coming on the types of infarct. To understand the type of infarcts, there are two types of infarcts in MI. Subendocardial infarct and full thickness or transmural infarct. To understand this, first you have to understand left ventricle. Can you see this diagram? Please focus on the left ventricular wall, not on the lumen. I'm asking you to focus on this. the wall of the left ventricle. On the next page, I will zoom it out. You see this portion, I will zoom it out. So on the next page, I will zoom this portion only. Can you see this is left ventricle? So this is the lumen of the left ventricle. This one is the lumen. The lumen. I'm focusing on the wall of the left ventricle. Can you see the wall of the left ventricle? Now the heart, the complete heart is lined by 3 layers: endocardium, myocardium, pericardium. So this is endocardial lining. This is endocardium in the left ventricle. Okay, this is left ventricular lumen. You can see it is filled with blood. You can see the wall of the left ventricle. It is having 3 layers. Endocardium. Okay, this is myocardium. This is complete myocardium. The myocardium is the thickest layer. It contains cardiomyocytes inside that. Cardiomyocytes are present in the myocardium. So this is complete myocardium. You can see. Can you appreciate the myocardium? And outermost layer is pericardium. So let me draw the pericardium now. Okay. So here I am drawing the pericardium. So this one is pericardium. So we have endocardium, myocardium, pericardium. Can you see the 3 layers? Endo, myo, peri. I have given 3 different colors to them. You can appreciate them well because I will divide the myocardium in 3 further portions. See, this is endocardium. You can see the innermost layer is endocardium. You all can appreciate. The middle layer is the myocardium. You can see with yellow color, and outermost is the pericardium. You all can see the pericardium well. This is pericardium, the outermost layer. See the 3 layers of the heart. Now divide the myocardium into 3 portions. We divide the myocardium into 3 portions. Let me divide it. You can see this portion is known as subendocardial portion. Subendocardial because it is just beneath the endocardium. Subendocardial portion. Okay, this portion. This portion of the myocardium, the complete portion of the myocardium is known as subendocardial. This is known as mid portion of the myocardium, mid fiber portion. Okay, and outermost is known as epicardial. This is mid myocardium and this is epicardial. The outer myocardium is known as epicardial. This portion is known as epicardial. So we are dividing the myocardium into 3 portions. Endocardium. So I am interested only in myocardium, not in endocardium and pericardium. Just for your understanding, I told you. So basically we are dividing the myocardium into 3 portions: innermost portion, middle portion, and outermost portion. The innermost portion is subendocardial. This is subendocardial. This portion is mid portion, mid fiber portion, and outermost portion is epicardial. So I hope you got it. So these are the 3 portions of the myocardium. Now you tell me, where is coronary? Can you tell me where is coronary and how does it do the blood supply to the left ventricle? Now if you see this diagram, can you see this diagram? Where is the coronary in this diagram? Can you appreciate the purple color coronary? This is coronary. You can see it is supplying the blood via small coronary branches from outer to inner side. Appreciate outer to inner. So let me draw coronary here to explain you the 2 types of infarcts. Okay. So where is the coronary artery? Here I am drawing the coronary artery. So suppose this is the coronary artery. And from the coronary artery, these are the small branches which are supplying the blood here. Small branches. So can you see it is supplying from outer to inner? Can you see it is supplying from outer to inner portion? Now suppose there is an obstruction in the coronary, the bigger coronary. In this coronary, suppose there is an obstruction. What will happen now? If there is an obstruction in the coronary, what will happen? You tell me what will happen now. So here the blood will not come or less blood will come. So all these coronaries have less blood in them. All these coronaries have less blood in them. They have less blood in them, the small coronaries. Now you tell me, use your common sense and tell me which portion of the myocardium undergo infarction first. The same 3 options you are having. The subendocardial portion of the myocardium, the middle portion of the myocardium, or the epicardial portion of the myocardium. Which portion of the, we divide the myocardium into 3 portions: inner, middle, and outer. So which portion of the myocardium undergo infarction first because of obstruction of the coronary? It's a common sense. So we can see the blood supply is from outer to inner side. You can see the blood supply is from outer to inner. So inner portion is already compromised. It is having end arteries. It is already compromised. Less blood is receiving. Least blood is receiving on the inner side because these are the end arteries. Arteries are ending here, small coronary arteries. Okay. So it is already compromised. Now, if there is an obstruction, it is the inner portion where the infarction occurs first. Infarction always starts from the inner portion. So you can see here, this is the portion from where the infarction will start. This is the portion. So this is known as subendocardial infarction. What it is known as? Subendocardial. Subendocardial infarction, subendocardial portion of the myocardium will get infarcted. It is known as subendocardial infarction. Okay. And gradually, if the obstruction is not opened, it is not relieved, it will keep on growing. And a point will come when full thickness infarct will be there. Through and through. Full thickness infarct. It is known as transmural infarct. So we have only two type of infarct. Subendocardial infarct, when the infarct start and gradually it will grow and it will lead to transmural infarct. So what are the two type of infarct? They are in front of you. This is subendocardial. Always starting occurs with subendocardial. Never forget. I told you the reason also. Because it is the inner portion which is compromised. So whenever there is an obstruction in the coronary, because the blood supply is from outer to inner. So it is the inner portion first which will lead to infarction. Inner portion get infarcted first. And gradually it will progress and it will lead to complete wall infarction, that is known as transmural infarction. So subendocardial infarction and transmural infarction, these are the two types of infarct. So same thing is shown to you here also. Can you see the two type of infarct? Now you can make it out. You can see in this diagram, these are the two lumen. This is right ventricular lumen, this is left ventricular lumen. See the left ventricular lumen. I'm interested in left ventricle. See the walls of the left ventricle. In the walls of the left ventricle, can you see here the infarct is starting? So when the infarct is starting, which portion of the myocardium got infarcted? Subendocardial. And gradually it will progress and it will lead to full thickness infarction, that is transmural. So subendocardial and transmural. So I will show you a video also. Okay, you can see the same thing here. You can see this is subendocardial. Only inner portion of the myocardium is infarcted. It is subendocardial. And this one is transmural. The labeling is opposite. This one is transmural and this one is subendocardial. So you can see this one is subendocardial and this one is transmural, the full thickness infarct. Okay, the same thing is shown to you here also. You can see this is the coronary artery. Currently it's open. You can see the lumen is open. Currently it is open and suddenly if it is got obstructed, so currently the infarct is not started. Now when got obstructed, first the infarct occurs subendocardial. Then it will progress and one point will come, it will be full thickness infarct, that is transmural infarct. You can see. So in 2 hours, it is just subendocardial and gradually it is progressing and it is happening. Within 24 hours, it is happening transmural infarct. You can see here, you can see the lumen. This is the lumen of the left ventricle. The lumen of the left ventricle. So infarct is first starting subendocardial, it is progressing. It is progressing. With time, it is progressing. Again, with time, it's progressing. And after some time, it is transmural, the full thickness. You can appreciate. So it is always starting subendocardial. So this is subendocardial infarct. Subendocardial infarct. It is progressing towards transmural. It is progressing towards transmural. And in some time, it will be actually transmural. Transmural is full thickness. So these are the two type of infarct. Now, what is the location of infarct? I already told you the location of the infarct depends on the branch of the coronary. There are three type of coronary arteries. What are the three type of coronary arteries? Left anterior descending, left circumflex, and right coronary artery. Left coronary artery have two branches, right don't have any further branch. So total 3 coronaries are there. You already know that. So if LAD is obstructed, there will be an infarct in the anterior wall because LAD supply the anterior wall. If LCX is obstructed, there will be an infarct in the lateral wall because LCX supply the lateral wall. And if RCA got obstructed, there will be an infarct in the posterior wall. So because RCA supply the posterior wall, so you can see the 3 wall, anterior, posterior and lateral. So which coronary got obstructed, it is causing the obstruction, infarction in which wall. So there are 3 type of coronary, LCA, LAD, it's LAD, LCX and RCA. Left anterior descending, left circumflex and right coronary artery. So if LAD got obstructed, it supply anterior wall, so there will be an infarct in anterior wall. RCA supply lateral wall, so there is an infarct in lateral wall. LCX and RCA supply posterior wall, so there will be an infarct in the posterior wall. So you have to learn that. And you can see the same in the diagram also. Okay, now each of them have two possibility, whether they are partially obstructed or completely obstructed. Okay, so they are supplying these wall. So if LAD is partially obstructed or completely obstructed, LCX is partially obstructed or completely obstructed. RCA is partially obstructed or completely obstructed. So partial or complete obstruction in each of them. If there is partial obstruction, each of them leads to subendocardial infarct of that wall. And if complete obstruction is there, each of them lead to transmural infarct of that wall. So we will be having 6 type of infarct. All the 6 diagrams are in front of you. I hope you got it. I will show you here. You can see the central diagram first. Can you see the central diagram? Appreciate the central diagram. In this diagram, you can see this is right ventricular lumen. This is left ventricular lumen. I'm interested in left ventricle. See the wall of the left ventricle. See the 3 coronaries. Can you see which coronary is this? Since it is anterior wall, so of course it is not labeled, but you know it is LED because LED supply anterior wall. You can see this is lateral wall. So of course it is LCX because LCX supply lateral wall. And this is RCA because it is the posterior wall. RCA supply posterior wall. So even if there is no labeling, you can understand which coronary is there. Okay, so you can see the 3 coronaries. Now we will obstruct these 3 coronaries one by one, first complete and then partial. See the complete. Now here LED is completely obstructed. Okay, so what is happening? There is transmural infarct. There is transmural infarct of anterior wall. If LED is partially obstructed, there is anterior wall only which is infarcted, but it is subendocardial. Now see the difference between the 2 diagrams. In both these diagrams, see in both these diagrams, LED is obstructed. See the other 2 are patent. See here also LED is obstructed, but see it's complete. Here also LED is obstructed, but here it's partial. Appreciate the difference. Appreciate the difference. See infarct in anterior wall, here also, but here the infarct is transmural in nature because it is completely obstructed, and here the infarct is just starting. It is subendocardial. Gradually it will also progress to transmural if not corrected, but it is starting as subendocardial. You can see infarct in anterior wall only. Okay, now coming on the second artery. Second artery is LCX. You can see when LCX is obstructing, So if complete obstruction, it is the lateral wall which is having transmural infarction. And when partial obstruction is there of the LCX, there is global hypokinesia. It is not only lateral wall, the global hypokinesia can be there. Okay, and you can see same is occurring with the RCA. When RCA is completely obstructing, it is the posterior wall showing transmural infarct, and when it is partially obstructed, there can be a small intramural multiple ischemic hemorrhages can be there. Okay, so this is the complete diagram. You can understand. So depending on which branch of coronary artery is obstructed, we can locate the location of the infarct. Okay, now imagine I will be telling you the morphology of MI. In morphology of MI, I will be discussing 2 things. Morphology of MI, I will be discussing 2 things. The gross of MI and microscopy of MI. So why gross and microscopy is required? We do this only in a dead patient during autopsy, during postmortem. During autopsy or postmortem, we do the gross of the MI and microscopy of the MI, not in a live patient. In a live patient, we don't do biopsy of the heart. We don't open the heart for MI, never. Okay. So imagine a person is there. Imagine a person is there and person suddenly got dead. Okay, and it's a medico-legal case, suppose, and the police is suspecting some foul play. What is the cause of death of this person? The police is suspecting some foul play here. There was another person at the time of death with this person. We asked that person what happened to this person, why this person is dead. So that person is saying this person was having chest pain before the death, and maybe the cause of death is MI. But we are not sure, and because we are not sure and we are suspecting some foul play, so here we will do postmortem or autopsy of this dead body. Okay, now what is the purpose? Suppose I am the doctor who is performing postmortem on this person. So what is my purpose of autopsy? In autopsy, I want to know whether the cause of death is MI, yes or no. Okay, what is the timing of the death and what is the cause of the death? That is the main purpose for the autopsy in this case, in this medical legal case. So suppose I am the doctor who is performing autopsy on this person. So what I will do? So this is the person on which the dead body on which we are performing the autopsy, the postmortem. We will open the chest. We will take the heart out in a tray. Suppose this is the heart we have taken out. This is the heart of this dead person we have taken out. We want to see whether the heart have MI, yes or no. So we can come to know whether the cause of death is MI, yes or no. So this is the heart which we have taken out of the body of this dead person in a tray. Okay, and you can see the 4 chambers. You can see the 4 chambers in the heart. So what I will do? First, I will cut the entire heart into slices like this. Into slices. It's like this. I'm cutting at 0.1 centimeter. We are having multiple slices. at 0.1 centimeter each thickness. We are cutting the slices one by one, multiple slice. Now let me draw each slice. How does each slice look like? Each slice look like this. It is having two lumens. Okay, either the two auricle or the two ventricle. Suppose it is right ventricle, left ventricle. We are having the two lumen. Each slice look like this, and we are having many slices with us. We have to take each slice and look for the infarct in the wall of the left ventricle. So we have to focus on the left ventricle and look for the infarct in the wall of the left ventricle in each of the slice. In each of the slice, in all the slice, we have to look for that infarct. The infarct can be in anterior wall, can be in lateral wall, or can be in posterior wall. You see, ma'am, it's a very tedious job. And what if the infarct is very small and we miss it? Sometimes it can happen. The infarct is very small. You are taking one by one the slices. You are looking with a magnifying glass and looking for the infarct. If it is grossly visible, if it is a big infarct, it will be grossly visible. But what if the infarct is very small? It can go unnoticed. You are taking the slice. I can see the two lumens. This is right lumen. This is left ventricular lumen. In the wall of the left ventricle, I can't see any infarct, but there is a very minute infarct which I can miss. We do not want that. So what we will do, there is a dye, there is a stain available. The name of that stain is known as TTC. What is TTC? Tetraphenyl tetrazolium chloride. Tetraphenyl tetrazolium chloride. It's TTC. So it's red color stain. So take a jar, a big jar, fill it with TTC. Okay, fill it with TTC like this. Okay, and put all the slices you have cut 0.1 centimeter. You are having hundreds of slides with you. So all the slices you have to put inside it. I'm putting only one, but you have to put all. So suppose one of the slice is here. You can see the two lumen. You can see right ventricle, left ventricle. When you put all the slice inside this, so there is a property. TTC will stain. It is having a property. The property is that TTC give red color. It give red color to viable myocardium, viable cells, and it give no color. It give no color. It don't stain. It don't go inside the dead cell, the dead myocardium. It don't go inside the dead cell because TTC bind with an enzyme. The name of the enzyme is dehydrogenase enzyme, lactate dehydrogenase enzyme, LDH. It binds with the dehydrogenase enzyme, and dehydrogenase enzyme is present in the viable cell. Since the dead cell is ruptured, the enzyme is leaked out and they don't have this enzyme. That's why TTC don't bind with that. So TTC is a red color dye. It is giving red color only to viable cell because it is having the enzyme. TTC bind with LDH. LDH is present only in viable cell. Now suppose this is a slice. Can you see the slice? In this slice, this section, these all are cells in the left ventricle. There are millions of cells. I'm drawing few of them. These are cardiomyocytes in the wall of the left ventricle. Okay. Suppose this portion is infarcted. Suppose this portion is infarcted. I mean the cells of this portion are dead. Okay. So all other cells will take the red color stain. All other cells will take the red stain and they will become red in color. But this portion will take no stain. It will remain yellow or brown only because the normal color of the cardiac muscle is yellow or brown only. So it will be yellowish or you can say brownish. The normal color is brown, the muscle color. It is brown or yellow only. The remaining will be red. So if you take all the slices out and wash it and see it, now you can see a contrast. Even if it is a small infarct on a red contrast, the brown or yellow will stand up and you can make it out. This is the infarcted area. It looks like this. Now have a look. You can see the slice. Can you make out this is the infarcted area? This is a slice. Can you make out this is the infarcted area? If you don't stain with red, you can miss this portion. But here it is highlighted because of the contrast of red and brown or red and yellow color. Got it? So the non-infarcted, I mean viable myocardium, take the brick red color because it is having the enzyme dehydrogenase in that. But the dead area don't have that enzyme. So it will remain yellow only. So this is the purpose. Grossly, we can take it out in the entire heart. Where is the infarct? Where is the infarct? So you can see this is the heart of a dead person in which we are suspecting the cause of death is MI. You can see the four chambers. I'm interested in left ventricle. This is the wall of the left ventricle. Now in the entire wall of the left ventricle, where is the infarct? Is it here, 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 here? Where is the infarct? It can be anywhere. So I'm cutting the slices like this, like this, like this, like this. In which of the slices there is the infarct? It's very tedious to find it out. So we use the dye TTC, put all of them in TTC and TTC will stain the viable area, not the dead area, and you can make it out where is the dead area. So with the help of the TTC stain, you can tell whether MI is present or absent. Okay. So whether MI is present or absent by looking at the brown or yellow color of all the slice. Take all the slice one by one. Look where is the brown or yellow color. The complete slice will be red because it is viable. A portion can be non-stained. It can be brownish or yellowish in color, pale in color. So you can make it out this is infarct. So with the help of this, you can tell whether MI is present or not. So it is not merely sufficient to tell whether MI is present or not. Suppose it is present. Suppose I got the infarcted area. Can I make my postmortem report? So there is a dead body in front of me on which we are performing the autopsy or postmortem. The purpose of autopsy is to find out what is the cause of death of this person, whether the cause of death of this person is MI or not. So we have opened the chest, we have taken the heart out, we have cut the heart into multiple slices, put them in TTC, and we found the yellow or brown area. So infarct is present. So it is not sufficient. Maybe this infarct is 10-year-old. The wife of this person is saying that the person was having MI 10 years ago. Maybe it is that, it is not now the cause of death. Now the cause of death can be something else. So on gross, we can tell whether the infarct is present or absent, but we cannot tell the age of MI, the age of infarct. If you want to find out the age of infarct, you have to do the microscopy. So wherever you found the infarct, you have to cut that portion, make a slide of that, do the H&E stain, and look the microscopy, and that will tell you the exact age of the infarct. So you got the infarct here. So here is the infarct. You can see this is the yellowish area you are getting. So is it 2 hour old, or is it 2 month old, or is it 2 year old? Who is going to tell? Grossly all will look like this. Grossly all will look like a yellowish area on a red background. You can see, but is it just now 2 hour old or 2 month old or 2 year, or what is the age of this infarct? We can't tell grossly. We have to make a slide. So cut this yellow portion, and make slide. You know how to make the slide. You make the paraffin block and cut the slide and do H&E stain, and then we will tell the age of the infarct. So my point is that grossly and microscopically of MI, in case of MI, grossly we tell whether the MI is present or absent. If it is present, microscopically we see the age of MI. Age of MI is told microscopically only. So let's make the slide and let's see the microscopy. This is how we cut the slice. I told you now, we cut the slices here, multiple slices, 0.1 centimeter thickness we cut and put all of them. The normal slices look like this. Now it can have infarct. You can see small whitish color infarcts. You can see it's very difficult to see. Put them in TTC. Put all of them in TTC. They will become like this. If they have infarct, the yellow area will stand out on a red background. So this is how we perform the gross. Can you see? Can you see this portion? This is a real diagram you can see. So complete slice is red, but this portion is yellowish. It is not taking the stain. You can see this is the infarcted area. So it looks like this. Now coming on the microscopy. So microscopy tell us the age of infarct. It tell us the age of infarct. Okay. Now we divide them into 10 time zones. So under the 10 time zones, we have 10 type of diagrams. I will show you 10 diagrams. So looking at the slide, okay, you cut this portion and make a slide. What you can see in the slide, there are 10 diagrams. You match, your slide is matching with which diagram out of the 10. We are having 10 options, and depending on that, you can tell the time frame. So we are having 10 different diagrams. One by one, I will show you all. So first you learn the time zones, the 10 time zones we are talking about. So 0 to half hour, half to 4 hour, 4 to 12 hour, 12 to 24 hours. So one day, 24 hours means one day, 24 hours. So one day we divide into four different portions. So divide one day into 4 portions, 0 to half hour, half to 4 hour, 4 to 12 hour, and 12 to 24 hours. 24 hours means one day. So this is R, one day. Now after one day, it is 1 to 3 days, 3 to 7 days, 7 to 14 days, and 7 to 10 days, and 10 to 14 days. So these 4 things are for days. 4 things for R. This is how you have to learn the time zone. And 4 things are for days. And lastly, 2 things are for weeks. 2 to 8 week. 8 week means 2 months and more than 2 months. So this is how I learned. So R. Day. And after that, we have week and months. Total 10. 4 hour, 4 day, 1 week, 1 month. Now write the numbers. Numbers are important. Write down the numbers. So it is 0 to half hour, half to 4 hour, 4 to 12, 12 to 24. You have to learn that. Now come on days. 1 to 3 day, 3 to 7 day, 7 to 10 day, 10 to 14 day. 14 days means 2 weeks. It's 2 weeks, okay? So 2 to 8 week, and 8 week means 2 months. So more than 2 months, everything looks same. More than 2 months, I can't tell it is 3 months, 4 months, 5 months, 1 year, to everything looks same. More than 2 months means it's a scar. Okay, now I will show you 10 diagrams one by one. First, you learn the time zone. The simplest way, 4 of them are hour, 4 of them are days, 1 is week, 1 is month. This is how I learned. You have to learn the numbers. Okay, now one by one, I will show you the diagram of each of them. Let's have a look on the diagram. So 0 to half hour, it's normal only. It's normal only. You cannot make out the person is having MI. If you cut that portion between 0 to half hour and make a slide even, on the slide, everything is normal. Between 0 to half hour. So up to half hour, we will miss an infarct microscopically, and it is impossible to perform autopsy within half hour of the death. Imagine a person is dead. We have to shift it to the hospital. Even if the death is at the hospital, we have to do all the formalities, and there is a permission taken from the that local police station. You will get a permission to perform the autopsy. You have to take the permission, the consent from the relatives also to perform the autopsy or postmortem. So all these formalities will take 1 to 2, 2 to 3 hours, and after that the autopsy can be performed. Within half hour, it is impossible to perform. Even if we perform, we get nothing. Half hour, no change. After half hour to 4 hour, there is simply waviness. The earliest change is waviness. You get MCQ also here. The earliest change is waviness. What do you mean by waviness? Let me show you the waviness. Can you see the cardiac fibers here? See the lower portion of this diagram. In these, only 10 diagrams are there. In the 4 diagrams, the 10 diagrams are clubbed. Let me show you. See the lower portion of this. Can you see the cardiac myocytes? You can see these are the cardiac fibers normally. See, they are having the nucleus. Can you see? They have the nucleus here. They have normally nucleus. They have striations in them. These are the striations. They have the striations and they are having the nucleus, but normally they are straight. The only thing they are straight. But here, how can I look here? How they are looking? See the lower portion. How they are looking here? They are looking wavy, wavy. They are looking like wavy. This is known as waviness. They are not straight. They are wavy. Otherwise, they are normal. They have their normal nucleus. They have their normal striations. But only thing, they are wavy. Appreciate the waviness. Appreciate the waviness. Can you appreciate? But striations are normal. Nucleus is normal. So earliest change is waviness, which occur from half to 4 hour. You should be able to draw this diagram in your exam. Waviness should be appreciated. After that, 4 to 12 hour, there is coagulative necrosis. CN is coagulative necrosis. Can you see the upper portion of this diagram? Compare with lower. See the lower diagram, see the upper diagram. See this portion and see this portion. Can you see the lower portion? It is having the striations. It is having the striations. It is having the nucleus. Okay. Only thing, they are wavy. Otherwise, they are normal. But upper portion of the diagram, you can see dark pink color inside the fibers. Dark pink. No striation, no nucleus. So cytoplasmic details are lost. Okay. Nuclear details are also lost. Only morphology, architecture is maintained. Only the architecture. It's a coagulative necrosis. You know, you have seen my lecture on coagulative necrosis. So coagulative necrosis is the necrosis in which architecture is maintained, but cytoplasmic and nuclear details are lost. That is clearly visible here. See striations in lower diagram that are lost in our upper diagram. See nucleus in lower diagram that are lost in upper diagram. And we have only coagulative necrosis. So coagulative necrosis is there. Okay. Between 4 to 12 hour. 12 to 24 hour, along with coagulative necrosis, few neutrophils are there. Appreciate the word few. Few. Only few neutrophils are there. See upper diagram only. Can you appreciate that background is having few small dot-like structures? Can you appreciate these dots? The dots in the background. These all are neutrophils. These all are neutrophils, but they are few. So few neutrophils are there. Now come on, 1 to 3 days. 1 to 3 days coagulative necrosis, but brisk neutrophils. See this diagram. Can you appreciate the background? Appreciate the background. Abundant of neutrophils. See the first diagram, see the second diagram. In the first diagram also you can see the neutrophils here. Here also you can see, but appreciate. Here we have few neutrophils and here we have abundant, brisk neutrophils. Okay, appreciate the neutrophils. Here we are having brisk neutrophils. 3 to 7 days. Now neutrophils will start decreasing and macrophage will start arising. Okay, now see here. I will show you here. Can you see here? If you see here in the first diagram, all these cells which I have highlighted, the diagrams are very small, but they are multilobated. They all are neutrophil, but here few cells, maybe this one, if I zoom the diagram, you can see they are single nucleus. They are macrophages. Neutrophils will start falling and macrophage will start just appearing. So neutrophils are falling and macrophages start appearing. What does macrophage do? You know, macrophage eat the dead muscle. They eat the dead muscle. They eat coagulative necrosis, dead muscle. They start eating. They start eating everything. The macrophages will start eating everything now, and whatever left is known as granulation tissue. So after this, we are having the granulation tissue. After this 7 to 10 days, we are having granulation tissue just arising, and 10 to 14 days, granulation tissue will establish. And after that, collagen and scar. You can see this is collagen. This one is collagen and scar. And scar. Complete scar. Nothing will be there. It's scar. You can see here the lower portion is having the dead muscle. The upper portion is eaten, engulfed by the macrophages, and it is known as granulation tissue. Granulation tissue is having the vascularity, and background is having little bit of the collagen tissue. And collagen tissue and scar. This is how. So how to learn and how to look at the diagram, let me show you. So first of all, in the microscopy, write down the time zone. The most important thing, you have to write down the time zone. So we are having R, day, week and month. This is how I always learn. So it is 0 to half hour, half to 4 hour, 4 to 12 hour, 12 to 24 hour. 24 hour means 1 day. 1 to 3 day, 3 to 7 day, 7 to 10 day, 10 to 14 day. 14 day means 2 week. 2 to 8 week, 8 week means 2 month. More than 2 month, everything is same. Okay, so these are the 10 things we are having, and you have to learn them, and you have to draw their diagram. I want you to draw 10 diagrams. Here you just draw normal diagram. Nothing. Normal means normal. Okay, here you just show waviness. Okay, the cells are normal, the fibers are normal, they are having striations, they are having nucleus. Only thing, they are wavy. Here they are straight. I will draw the diagrams also. So here I will draw the diagram like this. The fiber is straight. It is having the nucleus, syncytia. It is having the striations also. Everything is very good here. Okay. The only thing here, it's wavy. But it is having the nucleus. It is having the cytoplasmic details, that is striations. The only thing, it's wavy. This is my second diagram. Thirdly, it's coagulative necrosis. Okay. So here we will draw the muscle fiber. Okay. It's like this, but it is completely necrosed. All the details are lost. All the details are lost. Only architecture is there. Okay, but inner details are lost. No cytoplasmic details, no nuclear details. Striations are gone, nucleus is gone. So it's coagulative necrosis. In the fourth diagram, along with coagulative necrosis, we have to show few neutrophils. Okay, few neutrophils. So draw a diagram like this, in which you are drawing the fiber. It is having the coagulative necrosis, and surrounding it, draw few neutrophils, multilobated cells. Typically show their multilobated nucleus. I am trying to draw the multilobated few neutrophils. In the next diagram, again draw coagulative necrosis, but brisk, abundant, brisk neutrophil. So again you draw the same. Draw coagulative necrosis, but surrounding it, this is a muscle fiber showing coagulative necrosis. Draw many neutrophils. Draw abundant neutrophils. Now 3 to 7 days, neutrophils decrease and macrophage will increase. Okay, so draw same. You have to draw the coagulative necrosis, but you have to show few neutrophils, and you can show 1-2 macrophages also. Macrophage have single nucleus. So with the help of nucleus, you can differentiate the cell, the neutrophils and the macrophage. Okay, now macrophage start eating the dead muscle and show the granulation tissue. So you have to show the granulation tissue here, collagen here, and scar here. You have to draw all these diagrams. So 10 diagrams you can draw it separately. I have compiled the 10 diagrams in these 4. I hope you all got it. Now coming on the clinical features of MI. What are the clinical features of MI? The first feature is always pain. Patient complains of severe chest pain. It's sudden, it's severe, it's crushing in nature, it's prolonged. It's not like angina, which is on rest, it is just disappearing. No, it is prolonged, it is substernal, precordial in location, it is unrelieved by rest. No, to differentiate it from angina. It is unrelieved by nitroglycerin. Again, to differentiate it from the angina. It is radiating to the arms and the neck and the back. Radiating to the arm, neck and back. It is sudden, severe, prolonged, crushing, not relieved by rest, not relieved by nitroglycerin, and radiating to the arm, neck and the back. Okay, whenever we have severe pain anywhere in the body, we have acidity. So due to the acidity, the person can have indigestion, the person can have epigastric pain, nausea, vomiting, because the person is having severe pain because of which it is severe acidity. The person can go in shock. What do you mean by shock? Now see, the left ventricle is not pumping because the wall of the left ventricle, a portion of the wall of the left ventricle is dead. Suppose this portion is infarcted. So a portion of the left ventricle is not participating in contracting. Left ventricle is not participating, it is not contracting very well. So less blood is coming in the aorta. So all the organs are receiving less blood, all organs. So that's why the person is in shock. It's hypovolumic shock. All organs are receiving less blood. I'm sorry, it's cardiogenic shock. All organs are receiving less blood because heart is not contracting properly. Kidney is also receiving less blood. One of the organ is kidney. It is also receiving less blood. That's why there is oliguria. Now left ventricle is not contracting, so blood is not going in aorta. So where does the blood go? Blood go backward. Because it is not moving forward, it will go backward. Normally when the left ventricle pump, it ejects blood in the aorta. But here the left ventricle is not pumping properly. So blood is going backward from left ventricle to left auricle. From left auricle, it will go to the pulmonary vein, and via pulmonary vein, it will go to the lungs and leads to acute pulmonary edema. Patient presents with dyspnea or orthopnea. These are the clinical features. Now, how you will do the diagnosis of this patient? Suppose this patient is in front of me in the night, in emergency or anytime. This patient is in front of me and I'm suspecting it's a case of MI. It's a emergency. It's a medical emergency. You do 2 investigations only. Don't waste your time in unnecessary investigation. You do only 2 investigation urgently. It's an emergency condition. MI, you can save the patient. Just do two things. Number 1, do ECG. Emergency. You do ECG and you take the blood sample of that patient and send it to the laboratory for doing cardiac markers on the serum. So you take serum sample, blood sample. So you do ECG and cardiac markers serum sample. This you have to send it to the laboratory and write down urgent on this. It's very urgent to inform the report immediately on phone only. Don't wait for the printed report. On phone only you can ask the report from the pathologist in the laboratory. Okay. So here we are doing 2 things, ECG and cardiac markers. In the ECG, 3 things are there. You have to look. Number 1, ST segment elevation. You can see here is ST segment elevation. Here T wave inversion and here deep Q wave. ST elevation, T inversion and deep Q wave. Any of them can be there. It indicates MI along with the symptoms. So 3 things are there. You have to learn 3 ECG changes that indicate MI. What are the 3 things? ST elevation, you can see and you have to draw it. T inversion, T wave inversion and deep Q wave. You have to draw it. Okay. And what you will see in the cardiac markers, I told you now. Suppose this is left ventricle, the wall of the left ventricle. This is the lumen of the left ventricle. And these are the cells, cardiomyocytes present in the wall of the left ventricle. And you can see this is the artery or the blood, coronary artery, the blood supply. Okay. Now suppose this portion is infarcted. So cells in this portion are ruptured. Yes or no? So this cell is ruptured, this cell is ruptured, this cell is ruptured. These cells are ruptured. Infarcted means rupture. The coagulated necrosis, the cells are ruptured. When a cell rupture, the enzymes present in that cell will leak in the blood. So there are 5 types of enzymes. So here these enzymes will leak in the blood. These are enzymes which are coming by the ruptured cell in the blood. So you are taking the blood sample in a test tube and looking for these enzymes which are known as cardiac markers. So these enzymes are known as cardiac markers. There are 5 enzymes which are known as cardiac markers. So in the blood, we will test the level of these 5 one by one. If they are elevated, it means it can indirect evidence the person is having MI. So we are taking the blood sample. Okay. In the blood, we are looking for cardiac markers, the level of cardiac markers, whether it is elevated or normal. So what are cardiac markers? These are enzymes which are released by the ruptured cardiac cell in the blood. So we are taking a blood sample and looking for it. So what are the 5 types? You can see these are the 5 types of the cardiac markers. What are the name of the 5 types of cardiac markers? We are having myoglobin, CPK-MB, troponin T, troponin I, AST also known as SGOT and LDH. These are the 5 enzymes which are released by the ruptured cell, ruptured cardiac cell in the blood. So among them, earliest to appear within 2 hours, earliest to appear is myoglobin. You get an MCQ also. It is the earliest marker, but it is non-specific. As I told you, when the cardiac cell rupture, it is coming in the blood, but any cell of the body, other muscle cells of the body, maybe skeletal muscle also, it is rupturing. it will be there in the blood. So it is present in all muscles, not in only cardiac muscle. So if you are getting myoglobin in the blood, it is not necessary the person is having MI. It is the thing that some of the muscle in the body, some of the muscle cell got ruptured. Maybe it is cardiac muscle, maybe it is skeletal muscle. It is earliest but not specific. Second is CPK-MB. It occurs within 2 to 4 hours. Its level increases in blood. But it is sensitive. It is specific. It is marker of choice for reinfarction because it rises and within 3 days it goes away. So if there is a reinfarction after 3 days, it is a marker of choice for reinfarction. Troponin T and troponin I are the marker which are present only in cardiac muscle, no other muscle. That's why it is the most sensitive and specific marker for MI. They are present only. So if someone's blood, troponin T and I, it is elevated, of course the person is having MI, no alternative diagnosis. Troponin T, troponin I are the most sensitive and most specific marker for MI because these enzymes, troponin T and I, they are present only in heart muscles, no other cell in the body. SGOT or AST, again it's non-specific. LDH, late to come and late to go. So it is the latest marker which remain in the blood. It is the only marker which remain in blood even after 10 days. But it's non-specific. So you have to learn the name of these enzymes. These are the 5 cardiac markers. You have to look their values in the blood and you have to do the ECG also. And based on which the diagnosis is there, the person is having MI. You can see when these markers are coming in blood, when they are peaking and when they go away. You can see the 5 markers, the important one. Okay, now what are the complications of MI? The last thing, the complication. The most common complication of MI is arrhythmia. Because a portion of the heart, the left ventricular muscle, is not participating in contraction. So there can be irregular heartbeat and that is known as arrhythmia. That is the most common cause of death also in MI patient. Okay, the second is heart failure. When the left ventricle is not contracting, all the organs are not receiving blood. So that is heart failure, cardiogenic shock and rupture can be there. You can see rupture can also be there. It can be aneurysm. Instead of rupture, it can be just dilatation. It can be aneurysm. It can be pericarditis. And there is a syndrome known as Dressler syndrome. It is post-MI infarction syndrome. It occurs 1 to 6 weeks after an MI and person have pneumonitis in this. So that is known as Dressler syndrome. So we are done with the topic MI. Basically, we are done with the topic ischemic heart disease, also known as coronary artery disease. So first I'll let you understand what is ischemic heart disease or coronary artery disease. So it is the imbalance between demand and supply of the heart, demand and supply of myocardial oxygen. If there is an imbalance between that. Now we have understood the coronary artery distribution, the 3 types of the coronary, LAD, LCX and RCA, and which portion of the heart they are supplying. We have seen 4 types of IHD. Among them, we have discussed 2 in detail. We have discussed angina in detail and MI in detail. Angina and MI, one thing is common in both of them. There is imbalance between demand and supply. So here also coronary artery is obstructed. Here also coronary artery is obstructed. But here, due to obstruction of the coronary, there is transient ischemia of the left ventricle. And here there is infarction of the left ventricle, which is permanent. Here the muscle is dead. Here muscle is not dead, only ischemia is there. That is the biggest difference between them. Here we have seen the 3 types of angina, stable, unstable and Prinzmetal, depending what is the cause of obstruction of coronary. In stable, the cause of obstruction is atherosclerosis. In unstable, it is thrombosis. In Prinzmetal, it's vasospasm. We have seen the differences in their clinical features also. And there is a chest discomfort, which is paroxysmal and repeated. Repeated attacks are there. In MI, we have seen all these headings one by one. And most importantly, the morphology of MI, which we see in autopsy in postmortem patient, the gross and the microscopy. In the microscopy, I told you how to know the age of MI depending on the microscopy, the 10 time zones I have told you. So this is how you have to frame your answer. The most important among them is the morphology of MI. Very frequently you get question on that. So I hope you got the topic completely. So on the app, our app, that is MedLive by Dr. Priyanka, all the long question, short question, very short question of this topic for university exam are available. So I request you to visit the app, to open the app and go in the section and see all the questions which are already asked in various university exams from this topic. So you will be sure that you can be able to answer all of them. And if you are preparing for the competitive exam, you should have a look on the MCQ section of this topic and you should be able to solve all the MCQs of this topic. Thank you so much. All the best.